He graduated from He graduated from Jamia Hamdard University in 2006, and since then he has been working in Government of India hospitals in New Delhi for over a decade, and he's now currently in PGI Chandigarh since 2017. I welcome you, Dr. Pritpal Singh, and we're really looking forward to uh, this session of yours on, physical medicine and stroke rehabilitation. So I welcome you, Dr. Singh.
Thank you very much, Dr. Pooja.
So I think we can begin with the session.
Pooja, before I start, I have one statement to make. Ravi, are you there? Yes.
Yeah.
I think I just got information from our international president, UK, Dr. Yashwant Patil. He couldn't able to make it. He sent greetings and wishing all the best. And also the same message, I got it from the executive director of the ComHead International, Dr. Uday Bodankar. He's also sent a message to me, welcoming all this conference. And also we have with us Shiva, who is the secretary, very brilliant, effective secretary of the Bangalore IAP Bangalore branch. It has got nearly 1,500 members itself, city itself. And also our president Basuraj, he was on the way. He might be able to join us. And we have blessings of all these people with these things. And Jayoji Rao, who is the coordinator of the National International, he also sent a message. He's going to join it later on. With all these things, let's move forward. Pooja, over to you. Ravi, thank you very much. Give me 1 minute time to express these people's presence and wishes. Thank you very much. Go ahead, Pooja.
Thank you, sir. Thank you. So I think we can begin with our first session on stroke rehabilitation, which is by Dr. Pritpal Singh. Dr. Singh, you can now take the podium.
Thank you very much, Dr. Pooja, for the nice introduction. And thank you, President, sir, for allowing me to say whatever little I could present. And so can you, Dr. Ravi, can you share the screen?
Sure, sir. Just doing it. Okay, sir.
First of all, I welcome you all for this wonderful and very informative and intelligent sessions. And I thanks Dr. Ravi Kumar, who has worked tirelessly for getting all the big professionals here to come together on this bigger platform. And it is always a pleasure to learn something new and to discuss whatever I have learned in my whole area of practice for last 1.5 decades. So I'm gonna put some light in the occupational therapy role, what we do actually in stroke rehabilitation. So basically, first we should understand that I would not go into those details of the strokes, what is the anatomy and physiology, and what is the pathogenesis and what is the risk factor, because I think we already knew and covered it. So basically, what happens when a person is having a stroke? These days in India and in US as well, these stroke, hemiparesis, hemiplegia is one of the major concern to all the I think adult and to the infants also, because here I'm seeing a lot of pediatric neurologists here, so we have seen a lot of infantile stroke at as young as 1 year old and 2 year old and 10-year-old coming to our OPD. We call it young stroke and infantile stroke, and we call it young stroke as well. I have seen patient in my OPD who is just as young as 18-year-old or 20-year-old, and I've seen as old a patient who is 40 plus and 50 plus and 55 plus. So, sir,
Yeah.
do the next slide. So the first question that comes in our mind, that what is occupational therapy and why occupational therapy? Occupational therapy basically deals with the patients who is having this kind of problem, and they use different activities as a tool of therapy practice to improve the patient's cognitive status, to improve the mental status, and to improve his physical status. It's basically uses various activities and various exercises to help the patient achieve maximum level of independence, coming back to the society, whatever occupation he was doing or she was doing. So occupational therapists basically understand the person environment occupational model. It is suppose if a person is a driver, or is a computer professional, so occupational therapy basically understand what kind of basic skills he requires to again work in the pre-morbid state. So we use different kinds of strategies and different kinds of activities, especially designed and particularly designed for the patients, suitable for his recovery. And occupational therapy therapists understand the occupational roles. Roles are occupational roles. It can be defined as, suppose a person who is a housewife, or suppose a person who is a clerk, or suppose a person who is working. So that is his occupational roles. And his performance areas. Performance areas refers to the areas where he has to perform his goals. So we can analyze his activities, and then we have to assess what is his limitations and what is his ability, depending upon his thorough assessments, and then we combine all of them to provide a comprehensive program. To summarize this, and occupational therapy are basically a team player. So stroke rehabilitation involves a lot of, it involves multidisciplinary approach, team approach, in which there is a physiatrist who is on top of that, because these are PMR professionals, those who deals with the patient after the neurological intervention or the ICU intervention. The patient referred to the PMR department, or the physiatrist, then he assesses the patient. And we have different team members, we have occupational therapists, we have physiotherapists, we have clinical psychologists, we have speech therapists, and we have rehabilitation psychologists, we have orthotic engineers. They also play a very major role. And we have and we have rehabilitation nurses. They do have a beautiful role to play, because stroke rehabilitation itself, it's a big area, and that has to be covered by each and every team member. No member can say that they exclusively work on that. Occupational therapy is also a part of this, and they are very terrific team players. They understand what the other professionals do, and ensure that the patient get the best of the professional advice and care from the other professionals. Sir, can we go into the... And now, what occupational therapists bring change to the stroke patients. So they basically create a foundation for the caregivers, because once the patient is having a stroke, his whole area has been affected. Usually, most of the times they are dependent for his activities of daily living to their caregivers. Initially, for the few first weeks when the patient discharged from the ICU, or when the patient started his rehabilitation. So they create, occupational therapy basically create a foundation for the caregivers to understand the situation of a patient who has suffered a stroke. Because in India or in abroad also, there might be a lot of confusion and a lot of misinformation about what happens to the patient who has suffered a stroke. Sometimes the patient goes to a different kinds of jhola chhap, or we can say different kinds of masseur or massage therapist, because they were not aware of what has happened to the patient, and what is useful and what is not useful for the patient. So we strongly recommend the patient to get the professional help, and do not go here and there. And there are a lot of things that need to be done once the patient starts for the rehabilitation. The first and foremost thing that the occupational therapy do is their home assessment and their home modification. And there are a lot of things that a patient needs to do when a patient started his rehabilitation. Suppose a person is having right hemiparesis, it means he has weakness over the right extremities. So we as an occupational therapy, we have to give a lot of stimulus, visual, auditory, and a lot of stimulus towards his affected side. Normally, what happens, the patient who is having right side of the weakness, he has started using his left side, and he ignores the right side. So after this, and his right side become more weaker. So we have to increase. Suppose we have to we have to arrange the door of the patient, so the window of the patient, the television set, the radio set, the telephone, and we have to talk the patient towards his affected side, so that he or she would get the maximum visual auditory cues, so that to revive his weaker side. And these are the very important things we have to manage his skin condition. There should not be bed sores. There should be we have to maintain his joint range of motion, and we have to take care of his shoulder is very important, because sometimes the patient is not able to get up on the bed or himself. So what the caregivers does, they unknowingly they just pull the affected extremity, and that causes shoulder end syndrome, and that causes sometimes the shoulder subluxation. That is quite a challenge for the therapist and the medical fraternity as well. So we have to check every aspects, and we have to train the caregivers and the patients toward the patient recovery. And and then how can a reference to an occupational therapist make a difference? Because a lot of people in India, they think that after a stroke only physiotherapists work, but it is not like that. Occupational therapy is as equally important for the rehabilitation of the patients. So what they bring change to the patient in the stroke rehabilitation, they are very trained to do a detailed rehab history, and they interact with the caregivers with empathy and a ear to listen, and provide enough medical information to reduce the anxiety. Once the patient is having a stroke, he is very anxious, his anxious level is very high. What will happen to me, and who will take care of my extremities who is not working? And there are certain patients who is in coma also. They are not able to come into their senses, so we use the coma stimulation therapy to improve arousal and awareness level. And we usually identify early complications like risk for DVT, risk for pressure ulcers, risk for musculoskeletal issues, and risk for muscle tone abnormality. And we have to assess the possible cognitive deficit and perceptual deficits in future that may occur. And we have to see the possible cortical sensory deficit and visual deficit as well. There's very interesting visual deficit that occurs in a stroke usually. That is, the patient is not able to perceive. Suppose if a patient, if you tell the patient to draw a whole clock, he is not able to he is not able to draw the whole clock. He'll draw the half only. This is called hemianopia. This is a very interesting features that comes in the stroke patients when he started recovering. And we determine the future functional implication on the patient outcomes. We go to the next slide, sir. And what happens in the subacute care? In subacute care, our role is to regaining movement which are outside the pattern synergies, to initiate early return to active use of the upper limb in self-care tasks. Because initially when the patient is in the ICU, he's having no power, he's no muscle tone, no muscle power. So we has to do the range of motion exercises to get the synergies pattern and to initiate early range of motion activities. And we counsel the family member, because the family members are the most anxious. So we have to counsel the family members in changing the roles to make a temporary shift for the smoother functioning. And we sensory train to the facilitate movement recovery. This is very important. And visual rehabilitation, we do perceptual rehabilitation, we do cognitive rehabilitation, and we do orthotic management. Orthotic management is one of the most emergency management that we do for the patient recovery. We use AFO. We all have aware of this, what AFO is required. We use the shoulder hand syndrome. We use the shoulder Bobat cap. We use the certain shoulder hand sprint to WHO, that is called wrist hand orthosis, to prevent any deformity and to contracture, and to maintain the good skin length, and to maintain any TA tightness. And we have to check the secondary complications prevention to prevent pressure sores and anxiety and depression. Sir. And these are the very important tool in occupational therapy practice. In a sense, the patient once started coming to rehabilitation, he is not able to walk properly. So we have to check and assess his wheelchair also. And we have a proper performer for assessing and prescribing a wheelchair. Next, sir. And this is the very important domain and area of the occupational therapy, ADL training. ADL is basically activity of daily living. In the activity of daily living, we have simple activities that was very simple for the patient earlier, but now after a stroke, he is having difficulty in feeding, in brushing, in toileting, in grooming, in dressing. and in mobility, community mobility, and in communications. So we have a lot of technique like occupational that we train the patient how to use different modified technique to help in feeding. If you train the patient how to feed himself, if you train the patient how to go to the toilet, if you train the patient how to get up from the bed, this is a very big deal, and the patient will become very happy, and he'll become very cooperative for the therapy once he start doing this. And we have to train the basically how to dress himself and dress himself. This is a very challenging role for the patients once he is having a stroke. So we especially train the occupational therapy, especially train patient how to donning and doffing of the shirt and pant, and donning and doffing of the shoes, and we smartly train the patient how to change himself. And the second thing is that the work activity, because once the patient is a stroke, a paralytic patient, so the thing is that he is not able to work what he was doing earlier. So we have to engage in certain activities which can facilitate him to work again to the community and to work again with the maximum independence. That's what occupational therapy does. Suppose a person who was working on a desk job, and he had a stroke, so we try to simulate his work design activities in our occupational therapy department, where he has to write himself, he has to do a lot of activities so that he's prepared himself well after the rehabilitation program to go back to the to work office, and to actively earn his livelihood, and to become a productive member of the society. And the one more very important thing that the people always overrule, the leisure activities, because we as an occupational therapy, we have to balance between the work and self-care and leisure. So what happens in the most medical fraternity, we take care of the work and the self-care, we forgot the leisure is one of the most important thing one should do. So whatever leisure activities, depending upon whatever leisure activity is he or he is having, depend upon his area of interest, so we design that also. And socialization is very important for the patient, because the patient feels lonely and socially not very happy, so we have to increase his socialization also. And 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 we have to train him in instrumental activity of daily living, like he has to use how to use the home appliances, like simple gas, turning off gas and turning on gas, use the telephone, use the television set, and how to use the banking ATM, and how to use the Facebook and computer. So we as an organization, we train the patient, we for these areas also. These are also usually not looked, but these are very important aspect where we work. And but sometimes the patient again sometimes all this training is not for all patients, and we have to design as per the patient requirement, his age group and his religion and ethnicity. We have to take care of this. Next, sir. So there are a lot of conditions that occurs after a stroke. It's very challenging, and there is something called field loss and visual neglect that I told.
Dr. Singh, we have 5 minutes more.
Okay. So, sir, can we go to the next slide? Like visual deficit, I spoke, a certain patient is having this kind of problem. So these are very challenging problems. So we have designed specially activities and therapy program for them, exclusively in occupational therapy department, to train and basically to improve his visual field deficits. And in chronic care, because they sometimes the stroke, the patient recover in they have maximum recovery in first 6 months to 1 year, but sometimes the patient is not able to recover well in 1 year. Then the patient used to come to the department for a longer period. So now as in chronic care, we have to continue his range of motion, his regaining movement exercises, where we use a lot of things like standings. We have in occupational therapy department, where we train the patients to use and maintain his range of motion exercises, and we counsel the family members. And this is very important, because the patient is only going to bounce back if his family is supporting enough. And we have to train his sensory training. Sometimes the patient is having abnormal sensations, so we have to train his sensory retraining as well. And visual rehabilitation and perceptual rehabilitation, this is a very important rehabilitation, where we have to design a lot of things, and we have got a lot of equipment so for that. And we have to train him in daily life cognitive rehabilitation. We have to train the patients simple arithmetic calculation and simple visual cues, how to use his brain more effectively in the daily life, and social reintegration, because one has to live in the society. So how he has to going to his accept his problem and have to go to back to the society. And sometimes we have to do the modification also in his activities of daily living and his daily life. We have to modify his shoes, we have to modify his AFO, we have to modify his hand function, we have to modify his cars, and we have to modify his ramp and his chairs and this thing. And we have to give some job exploration. Sometimes the patient, suppose if a patient was a driver and he had a stroke, so he's not able to drive anymore the vehicle that he was used to. So we have to explore whatever capability he has, and depending upon his ability and capability, we have to modify the job and help him to regain his previous job, or to get a new job. Next. And these are very good exercises that we do for the patient, like muscle tone management. These are very crucial exercises for the patient, and in which we use different approaches like roots approaches, Brunestrom approaches, PNF. I'll not go into those details. These are basically the treatment approaches that we use for the patient having stroke. And these are very effective PNF techniques. And if there is after using these techniques, if the patient is not having his tone improved, then we refer the patient for the neurology for the spasticity modulation, where they give the medicines. And one more thing, that is we as an occupational therapy work for the barrier-free environment evaluation. Now in this area of technology, we have heard and we see a lot of things where this is a barrier-free environment. The patient who is having disability, who is not able to, he's having limb weakness. So we have to assess his wheelchair, his environmental modification, and so that he can use his maximum level of independence, whatever environment he or she is going. And there are the very important thing that I wanted to convey to all of you senior doctors and fellow therapists, that occupational therapy cannot be done by a physiotherapist. Physiotherapy is quite different, and occupational therapy is quite different. And occupational therapy is way beyond the only physical aspect of the rehabilitation. It relies on the knowledge to understanding the perception of individuality, which cannot be learned just by seeing it. It has to be learned and practiced. Occupational therapy is the tool to paint the patient canvas of life. Without the stroke, rehabilitation is just incomplete. Oh, thank you very much, sir, and thank you for the precious times that you all are here, and I'm honored. Now over to you, Dr. Ravi.
Thank you, sir. Dr. Pooja, please carry on.
Thank you so much, Dr. Singh. I was when I was listening to you, you know how nicely and comprehensively you actually have put explained to us an ICF model of stroke rehabilitation through occupational therapy. The end goal being the person's participation, bringing back the person, back to the society, back to his maximal functional ability. So that was really, concisely and very nicely introduced, including the approaches and how occupational therapist, views the person as a whole and not just one aspect. Every aspect of that person is important to be back to his maximal functional ability. And that is, how nicely you explained. I was just remembering the ICF, through what you were explaining, and different approaches, can help us.
And it cannot be summarized in 10-20 minutes, Dr. Ravi, and
Yes.
we also. But I try to maximize what I didn't went to all the details, and I try to introduce occupational therapy to all the fellow professionals. What change we can do a patient who is having a stroke.
Yes, absolutely. At least, we can understand, everybody can understand, the role that an OT plays in, complete management of the patient. So wonderful session, doctor.
Thank you very much.
Yes, I now invite Dr. Anjali Joshi, who will speak to us on sensory integration in autism spectrum disorder. So looking forward to a wonderful learning from you, ma'am. So over to you, Anjali, ma'am.
Thank you, Pooja. And let me share my screen here. Okay. I think most importantly, I would like to thank Omad before I begin, IIPBPS, for inviting me over here today. I really appreciate the effort made by medical professionals to understand what their co-professionals do and how one can work towards rehabilitation of any individual, adult or child. Today, I'm going to just briefly introduce to you what is the role of occupational therapist in children with autism. And specifically, I'm going to try and highlight the sensory dysfunctions and what an autist does. It's going to be a very, very brief presentation, as you can see. But the objective is to just highlight certain key points. 1 second. Okay. I'm going to begin with a story of this little Karan. Little Karan is a 3-year-old boy.
Ma'am, you are on mute.
Oh, I'm so sorry. Yeah. Oh, I'm sorry. Let me go back then. Let me go back. I'm so sorry. Okay. Yeah, let me go back. So just to quickly share with you what I'm going to talk about today, I'm going to talk to you about intervention, occupational therapy intervention for children with autism, with special reference to sensory dysfunctions and what we do for sensory dysfunctions. I once again would like to thank Umeed and IIPBPS for inviting me over here. And I really appreciate the effort made by medical professionals to invite co-professionals to understand the role that all of us, I mean, as a team, what we can do for an individual with any kind of disability. I'm going to begin my presentation with a story of this little Karan. Karan is a 3-year-old little boy with autism who is receiving occupational and speech therapy since past 1 year. He can say ball and papa for water and tata when he wants to go out. He stands in front of the TV when he wants his mother to switch on the TV for his favorite program. Karan dislikes teeth brushing, nail and hair cutting, and resists eating solid food. But he often mouths non-edible items. His parents feel helpless when they see him bang his head or throw tantrums for trivial reasons. All the professionals here must have come across at least one little Karan like this in their practice. So with this story of Karan, I'll walk you through what we do as autists. So in my assessment as an OT, when I look at Karan, most importantly, a therapist is going to focus on what are Karan's functional challenges. The functional challenges I see through my observation, evaluation, and history from the parent that he's a picky dresser and a toe walker. He tends to walk on his toes is one of the concerns. He dislikes getting his hands messy and walking bare feet. He closes ears with loud noises. He's not toilet trained as yet and can't tolerate changes in routines and resists learning new tasks. So these are some of the areas which are going to hamper Karan's learning per se. Now, with this story of Karan, let me introduce you to sensory systems and their dysfunctions. All of us here are familiar with our 5 senses, so I don't have to really elaborate on that. So there are those, besides these 5 senses, when we talk about sensory systems or sensory integration per se, we talk about 3 other senses. One of them is the vestibular sense, which is responsible for body tone, posture, and balance. Proprioceptive sense or a joint sense, which is responsible for motor control, grading of movement, postural stability, and the interoceptors. Recently, or more research in the recent few decades or so, and this is the system, this is the sense which is important for sensation, or it's responsible for sensation of hunger, thirst, sleep, defecation, and urination. So these 8 systems together are the core systems of what we call is as sensory integration. And why? Because all these 8 senses work as a team and play a key role in maintaining awareness of the surrounding and sustaining alertness. So the optimal alertness level of the nervous system is very much responsible or very much dependent on how well these sensory systems work together as a team. which is important because the new learning can happen only if there is an optimal state of alertness or arousal maintained by the brain or the nervous system, and which also then therefore protects us from incoming threat, functions crucial for human development and learning. So the sensory integration, what we mean is all these 8 senses exchanging information, sharing information, working as a team to process the inputs that are coming in from the environment around us. This whole concept of sensory integration, the theory and the practice, was developed by Dr. Jean Ayers, and she called it as the process of brain organizing various sensations. And she was a psychologist and an occupational therapist, and her extensive research on animals and then later on with children with learning disabilities, she evolved this theory. This was in the last 40 to 45 years. This theory has further evolved through research by various professionals, and the effect of sensory integration practice in children with various developmental disabilities have been tried and tested. Dr. Jean Ayers, when she started her work, it was primarily for children with learning disabilities. Now, this process of sensory integration is like any other developmental process. It's an ongoing learning. I'm sharing a diagram which most of you will relate with the pyramid of learning, and because a lot of learning, sensory integration is based on theories of learning. Now, what you see here is you're looking at 4 levels of maturation of brain or the nervous system in order to reach that optimal level of functioning that we are expecting in any human being or any child in this context. What happens at the level first, or the primary level, is there are those sensory systems which are working together with each other, they're interacting with each other. This interaction later on leads to the level 2 of skill acquirement, which is perception motor foundation. Understanding of right and left of body awareness, motor planning, all these are dependent on how well these sensory systems are sharing information or talking to each other. If the sensory systems are working well, then we are going to have a motor outcome, which is level 2, which is what is a perception motor foundation. If the perception motor foundation or the level 2 is functioning well, then we're going to see this level 3 of maturation, which is a perception motor skill acquisition. And what do I mean by perception motor skill acquisition? All these skills like the auditory, visual perception, visual motor coordination, more or less higher order functions or cortical level functions are what will emerge if this level 1 and level 2 is in sync. The last one, of course, is the frontal lobe functioning, something that we are hoping to have in all our children with special needs. So this academic readiness is very much dependent on how well the level 1, level 2, and level 3 is integrated. Problem with developmental disabilities, and therefore what we call it as the sensory processing dysfunctions, I'll go to that in a bit. So the problem with developmental disabilities, children with developmental disabilities who have sensory processing dysfunctions, is this, that they either have a difficulty or impairment at level 1 or at level 2 or at level 3, and therefore level 4 is a long drawn far-fetched dream for these children. So as a therapist, when I'm working with these children, I'm hoping that this child with my intervention reaches this level 4, but there's a possibility that that may not happen, and the child will have issues even at the level 3 level, which is so common what we see in all different disabilities. Problems with visual perception, visual motor coordination, auditory perception, entire perception motor skills, fine motor difficulties, and so on and so forth. So these are all 4 levels of sensory processing per se. Now, when we talk about dysfunction, so when I say sensory processing dysfunction, so in a normal neurotypical child, we're going to look at all these 4 levels, and we are hoping that with neuronal maturation, the child will reach at this level 4, and there is going to be academic readiness by the age of 6 or so. And the child will have a good, the child is going to reach a level what is expected by the time the child is 6. and the academics, the doors for academics open up for this child. And most importantly, not just for academics, we are also looking at how well coordinated this child is, and organized behavior, and so on and so forth. So this is a neurotypical child's path. This doesn't happen with children with developmental disabilities. And this is where we talk about sensory processing dysfunctions, or SPD. So what is SPD? It's inappropriate and or inconsistent response to sensory stimulation, and or difficulty organizing information coming from senses. As I said, integration means all these 8 senses need to work in harmony, in sync with each other, and share information. If that's not happening, then that results into what we call it as SPD, or sensory processing dysfunction. A large percentage of children with developmental disabilities have SPD, and with respect to autism, there is research which shows somewhere around 70 to 95% of children with autism have sensory processing dysfunction. All of us here in practice, who are in clinical practice, see children. Almost every child with autism has some sensory issue or the other. And what sensory issues? I'll come to that in a bit. So typically with SPD, the manifestations you will see in a child could be motor, postural, visomotor, socio-emotional, attention, academics, and functional difficulty. So it's literally across all the areas of development, you're going to see some kind of a deficit if there is SPD, or sensory processing dysfunction. So what do we, in brief, in nutshell, if I have to talk about SPD, what happens there? First, there is inefficient intake by brain. The sensory input is not coming correctly. And what do I mean by not coming correctly? It's either the brain is taking in too much or too little, and therefore there is hypo or hyper responsiveness. If the intake is not right, then obviously there is going to be inconsistent intake of messages, is going to lead to poor connectivity amongst each other. And that in turn is going to result into inefficient outcome or output, which is going to be visible from the motor, language, emotional, behavioral areas of a child with autism or other disabilities. So this is in nutshell, if I tell you about what is SPD. Now, what are the commonest features of sensory processing dysfunction? So what concerns or what complaints the parents will have if the child has sensory processing dysfunction? So some of the commonest issues are, he may dislike hair being brushed or cut, may be sensitive to light, may cry to get upset or get upset with clothing or textures, may be at excessive risk of risk taker, crashing into things, may have poor coordination. I mean, the list just goes on and on and on, as you can see here. So sensitivities to sounds, or no sensitivities to sound, or sensitivities to light, no sensitivity to light, communication difficulties, interaction difficulty, challenges in functional skill, all these things could have sensory processing as the root cause there. Now, to just give you in nutshell what, or most simplified, let me put it this way, a simplified classification of sensory processing dysfunction. So when as an OT, I'm assessing the sensory processing dysfunction, I'm looking at whether this child has sensory discrimination dysfunction, which will be presented in the form of disorder of motor planning or praxis. What we call it as, typically, one would call it as a clumsy child. So a child who's 2 and 3 onwards. So, one can see the red flags right from that age. And this is a child who requires monitoring by the pediatricians, and the parents need to be informed about what could be the repercussions of this clumsiness persisting for a long period of time. And that is what we call it as likely to be a child with sensory discrimination dysfunction. The other one is the sensory modulation dysfunction. This is classically what one would see in a child with autism, where this child is under or over responsive to sensory inputs. When we talk about sensory discrimination, so again, what would be the manifestations? This is a child who has difficulty discriminating sensory inputs coming in from one or multiple sources, such as touch, movement, body position, body schema, or direction. So the information that's coming in from all the sensory sources, if this child is not able to discriminate, not able to register and discriminate, there are going to be challenges. And those challenges will be when we clinically evaluate this child, the challenges will be manifested as dyspraxia or motor planning problem. To simple words, clumsy child, poor bilateral motor coordination, difficulty with handwriting, difficulty with doing engaging in play which requires two hands, difficulty learning to tie shoelaces, difficulty learning to ride a cycle, difficulty eating appropriately, finger feeding himself or herself, classical initial level of issues, and then of course problem in motor planning. This child will have difficulty going on to playing on a jungle gym or going on the swing. He may be comfortable doing it in a place where he has been practicing it over and over again, but the minute he goes to a new park, this child looks lost completely. This child is somebody who's going to complain about saying somebody has, like the other child tried to hit me, and the other child would say that, oh, I didn't really hit him, I just touched him like this. So he has difficulty discriminating between the soft touch and the firm touch, and this inconsistency results in issues or difficulties with motor skills too. So this is about sensory discrimination disorder. Then, as I said, the next one was the sensory modulation dysfunction. Inefficient ability to regulate and organize the sensory inputs in a graded and adaptive manner. This is a very SMD or sensory modulation dysfunction is a very complex condition or a complex manifestation of sensory processing dysfunction. It refers to physiological and behavioral responses. And here, this is SMD or sensory modulation dysfunction is what makes the child with autism extremely unpredictable. It's very hard to predict what's going to be the child's behavior. And very often, when the uninformed people are likely to call this child a spoiled brat because he exhibits some extremely exaggerated responses to trivial inputs or trivial situations. And that's not what it is. So SMD is a huge issue with children with autism, and it really impacts their learning. Now, and when we talk about modulation, and like as the word says, modulation, that we are able to modulate or control the input that's coming in. So internally, a typical brain is able to control and modulate the information which is coming in. But in a brain of a child with autism or with any other developmental disability, this becomes a challenge. And what happens, the manifestations would be that this child is either under responsive to a sensory input, or the brain is over responsive to a sensory input. And the third bit makes it all the more clumsy and complex, that there could be a combination of the two in the same child. And what do I mean by that? So when we're talking about under responsive or a child who's hyposensitive to sensory inputs, and how does this child, how will the child present to you? In a routine environment, the sensations are registered at lesser intensity. So in a regular environment, this child is not able to register the sensory inputs at an intensity at which we register it. And the child needs more sensory inputs to reach an optimal arousal level, and often misses out on routine sensations. And this child, the parents are likely to say that he never feels tired, or he doesn't recognize thirst, he doesn't ask for water, he does not feel pain, and we realize that he was hurt only when we see the bruise, he never cried, or the child took very long time or is taking very long.
You need a protector too, right? It is broken.
Somebody is talking here. In a routine environment, it may appear lethargic. The child may appear lethargic, sleepy, dreamy, unmotivated, or disinterested. And to counteract this state, that is where it makes it, difficult to deal with and handle. Because to counteract this particular state, this child is going to be a seeker of different inputs. He's constantly going to seek inputs because he needs to maintain that optimal level of alertness. And this is where the self-stimulatory behaviors like rocking, flapping, licking, banging, crashing, hitting self or others, making noises or seeking out noises. So all sorts of ways of alerting the sensory system, which is under responsive, the child is going to manifest different kinds of behavior. So this is where what we call it as an under responsive or a hyposensitive child who's now become a seeker because he wants to maintain an optimal alertness level to function in a normal environment or a routine environment. Whereas with an over responsive child, he in a routine environment, one or more sensations are registered as very intense or painful. He's over responding to the inputs that are coming in. So there's a possibility that he's over responsive to only one input, but most likely, in most of the cases, it's a combination. To cope with this state, this child prefers to avoid any change because every input is going to bother me. It's like a thorn or it's like poking me. Then best is to avoid any change in the incoming sensations. He may appear irritable, rigid, inflexible, aggressive when the structure and predictability is lost. All of us here as professionals, we are familiar with the concern that the parents have. Some change in his life and he drives us mad. We cannot even change the placement of furniture. We can't even change the placement of how we sit. And this, we do that and this child just loses it because the child does not want any break in his structure. He may show dislike for specific textures or smell, sounds, or even slightest movement. So the child may not like a certain kind of food, may not like a certain kind of food which is grainy or which is pureed or which is bland and so on. I mean, there could be n number of functional challenges that one would see when this child is avoiding any change or sensory inputs. But that's not where it ends. With children with autism, the other challenge is that one sees a combination of this under and over responsiveness. So this child, there is fluctuation between over and under responsiveness across one or all the sensory systems. So the child may seek sensory experiences on some days and avoid on the other days. So the parents will come up with things like, oh yes, he does not like a particular, he doesn't like to wear t-shirts or shirts with collars. And here is, the next day we saw this boy is continuously wearing his sweater with long sleeves and collar and doesn't want to get rid of it. On a day, on a particular day, this child was perfectly fine on a birthday party with so much noise and firecrackers and people touching and screaming and so on and so forth. And the next time we went, he just refused to enter into that party and we had to come back home. So this variation of responding to sensory inputs makes it extremely challenging. And that is why a lot of times a third person or an uninformed person may say that this child is spoiled brat because he doesn't know how to interact and engage with the environment, but that's not the case. So now let's go back to this current that we were talking about. So now we know what is sensory discrimination and modulation disorder. So current is showing combination of sensory discrimination, modulation dysfunction. The behavioral outcomes that we saw here is he had difficulty registering and chewing food, which could be because of low muscle tone and oral dyspraxia, which is sensory discrimination disorder. He has heightened response to touch during hair and nail cutting. He dislikes hair and nail cutting, if you remember, and brushing, teeth brushing, and difficulty to tolerate a change or learn a new skill. So the tantrums probably also could be coming out of that, which is what could be a sensory modulation dysfunction. Tantrums and meltdowns is subtle change in the environment, again, a classical feature of sensory modulation dysfunction and inconsistent adaptation to different sensory inputs. So all these complaints or the concerns parents had about Karan's behavioral manifestations or functional limitations, they could be strongly rooted in the sensory processing dysfunction that I spoke about. So now what does an OT do when it comes to supporting a child like Karan or supporting a child with autism or other developmental disabilities? The very, very basic and the most important tool that we have is the therapeutic play. All of you here, I mean, most of you probably are pediatricians or neurologists. Everybody is familiar with role of play or therapeutic value of play. And using play as a modality is a most effective method of connecting, interacting, and engaging with a child with autism. So play is one of the major important tools that we have. Other than that, of course, the sensory integration therapy if this child has sensory processing dysfunctions. We also work on the motor and cognitive deficits because autism is a spectrum. So there could be variety of dysfunctions or concerns in this child in across various developmental areas. And one of the areas could be very likely to be fine motor skills. Children with autism do not really come up with gross motor deficits, as all of you know. But when we assess this child, we're going to see challenges with writing, challenges with fine skills, challenges with coordination. So the fine motor skills and motor deficits is something that we will work on. Cognitive deficits, large percentage, over 70% of children with autism have intellectual impairment, and therefore cognitive deficits are going to be part and parcel of autism. And working along those, using theories of learning, using various techniques to address the cognitive deficits is another area that an autist will work upon. Very importantly, partnering with parents to develop strategies to modify home environment and mitigate child's challenging behaviors. Because the first thing that comes across, or the first concern anybody will voice when we talk about autism, is the behaviors. The parents will often come up and say that, if you could correct this behavior, everything else is manageable. If this behavior is not there, oh, he's a wonderful child. So it's the behavior which comes across, which hits us first when we're looking at a child with autism, and that affects the child's learning immensely. So how to deal with the challenging behaviors, how to address that. And often challenging behaviors have sensory as one of the components, one of the contributing factors. So indirectly, when we are working on the sensory areas, we are addressing the behaviors, but it's not necessarily that it's only behavior. It could be because of communication, it could be because of social engagement, it could be because of play deficits. So there are so many factors which would result in challenging behaviors. So addressing all those functions.
I'm sorry, ma'am, to interrupt you. We have 5 minutes left.
Absolutely, I'm done. So, and the long-term plan that we talk about as an autist is help the parents. And I think this is where we as autist occupational therapists stand out, because helping the parents to build routine-based intervention for functional independence. Therapy is, what therapy I offer is my forte and my area. Having said that, this child is going to be there with me only, say, for 3 or 4 sessions. I mean, somebody is really fortunate, then the child may get 4 sessions. With the number of therapists practicing and the number of children out there, 3-4 sessions is a luxury. So the child is going to get some 2 or 3 sessions in a week. It's just 3 hours of intervention. Rest of the time, it's the parents who are the therapists for this child. And training the parents to become better therapists is what an occupational therapist will do. And the best form of therapy the parents can offer is through play and through routine-based intervention to acquire functional independence. So that's something which an autist does. And that's where, that's how the occupational therapist will offer intervention to children with autism, or again, as I said, other developmental disabilities. So when will you refer a child to OT? So because there are so many medical professionals here, so I request you that as soon as the child is identified to be at risk for social and communication delays, or has already received a diagnosis of autism, because you see that this is clear ASD, then to mitigate the challenges in sensory processing, motor areas, social communication areas, play, functional skills, and cognitive or academic concerns. So any of these areas, and all these areas are going to be impaired in children with autism. And the parents will have concerns related to all these areas. And that's where you will refer the child to occupational therapist, and you will ensure the parents that all these areas can be addressed, and they can receive help with respect to all these areas from an occupational therapist. So in short, an occupational therapist provides care to children with developmental disabilities, and of course, autism comes under that, and training to parents to enhance developmental and functional independence. So with that, I come to an end of my presentation. I'm just sharing some reading references. I mean, the first initial 5 references are what typically an occupational therapist will use. The below that, I've given purposely given some references which you can share with your parents if they are struggling to understand the sensory dysfunctions in children. The YouTube links also are very, very useful because they help the parents understand the sensory dysfunctions that they often come across in their children, and they struggle to understand why is this child behaving the way he is behaving. So yes, I bring my presentation to end, and thank you for your patient listening.
Thanks a lot. Thank you so much, ma'am, for this wonderful and very, very crisp and concise understanding of how our sensory systems really work as a team, so that we are able to perform, functionally in our environment, and how they can, even if one's sensation, even if one sensory system is affected, how it can really, turn the life of a child with a developmental difference, and mostly children with autism, which occupational therapists really see, day-to-day basis. And almost every child we see has, sensory processing dysfunction. And very nicely and beautifully you explained to us with good examples, like what are these, how you can, it would have been nice to, listen to some strategies as well. Uh, but this is due to lack of time. But it was really nicely explained how we can really help these children, from right from, level 1, going up to the last level, of academic learning. It's a lengthy process for therapists and parents, and how we all can come together and help them. So I think we are open for discussion and questions, if anyone, any of you have, both to Dr. Pritpal Singh and Dr. Anjali Joshi. I request the audience to come up with questions if they have any.
Please unmute yourself and please ask the questions. Dr. Ushma, I think you have to unmute. I'll unmute you. Yeah.
Yeah. Okay.
Please go on.
Oh, okay. Okay. So thank you, both the presenters, for the excellent presentation. It was very nice to hear from both of you. And, it was a treat this evening. So for the first presentation on stroke for Dr. Pritpal Singh, I would just like to add one thing. Excellent presentation, but on what he said was treat the weak side, sensorically, motorically, all of that, which is great. We do all of that. But as a PT, and having been worked for more than 30 years now, hands-on, what I realize is that it's not only the weak side, but it's also the bimanual or the bilateral motor coordination for the lower extremity as well as the upper extremity, which also gets interrupted to maybe smaller or even to a gross extent in our patients with stroke across ages, from children to adults. So, the bimanual training, I think there are studies done on this, and bimanual training was brought by Columbia in New York, Columbia Hospital, and they published a lot of papers on that. I've only read 1 or 2 papers, but then, clinically, I've been observing this. So the thing is, for our young therapists here, whether they are PTs or OTs, we just don't focus on the weak side. We also focus on bringing in the good side for 2 reasons, is because the good side is not always good. There can be weaknesses, in the motor and sensory areas on the good side. So that is one reason. And the second reason is that, we need to train the body and the brain to work together. Bring in 2 sides together, as we do in real function in the world. So, this is my 2 cents and, my clinical experience. So that is what I would like to say. And Dr. Anjali Joshi, thank you so much. Because I'm also a sensory certified therapist. I teach courses. And I was really glad this evening to hear from someone else who affirms my views and my ideas. Sometimes you need a what you call affirmation from other people, other professionals also, to make sure that you are going in the right direction, or you are thinking in the right track, So that was great. But again, I'm a PT and I'm sensory certified. So I've been working with sensory integration since 1988 in the US. Now I'm in Bangalore, but since 1988, I have worked closely with OT. So coming from that background and that experience, what I find is that, yes, I mentioned in the chat box that I see that 100%, that is each and every child who walks into my clinic has sensory issues. This is my clinical experience. Okay. And the other thing is, there was there's this lot of talk on, yeah, and I mentioned in the chat box that with autism, 100% children have sensory issues. With ADHD, highly likely to have sensory issues. And then LD kids, I find a lot of vestibular proprioceptive and visual, you know, these three, because obviously these three along with tactile, but these three, when we find issues, then children have LD, you know, and that is why sensory integration helps a lot. Now, the other thing is motor. So autism children are okay with motor. Clinically, I don't agree with that, because this has been my observation right since 2007 or 8, since I started my doctorate program at Rutgers University in New Jersey. And there, even our experienced professors who used to teach us motor learning and, you know, all of those things, they would ask us, you know, every class or whatever, do you see in your subjects, do you see, or in your patients whom you treat, do you see motor deficits in children with autism? And mind you, 2007-8 was when, you know, the numbers were increasing in the US that time. And all the PTs would say, yes, we see motor deficits. Now, overall, they may be walking, they may be sitting, they may be sometimes jumping. But if you look at closely, they have difficulty jumping, meaning they would not clear the floor very well while jumping. They would be afraid of jumping even from an 18-inch or 20-inch height, you know, which is sort of the milestone for a 4-year-old or 3-year-old. They may be afraid to jump sometimes, again, related to the visual system, because they may have a depth perception issue. So maybe they may not have a difficulty jumping per se, but then because of the vision perception, depth perception issue, they have a difficulty. They are clumsy, obviously, we know, because of the probe. But my takeaway, I mean, my learning, and this is what I see, is that motor and sensory, I really don't know. As a PT and as a sensory certified clinician, I really don't know where sensory begins, sensory ends, motor begins, vice versa. You know, they go in parallel, or they go in tandem, or they go in hand in hand. That's what I explain to my parents, you know, in simple language, because, you know, parents often will tell you, nahi, yahi hai, bachcha bas yahi karta hai, yahi karta hai, yahi karta hai. Bas ye nahi karta, ye nahi karta. Aap itna kar do, as, you know, Dr. Anjali said, that please get rid of these, these behaviors, you know. So, you know, yes, so we ought to explain to them as clinicians that, you know, sensory and motor are both connected and feeding to each other. And, you know, you cannot just tease out one and only focus on the other. This is my, you know, my 2 cents. And this I've seen across ages, again, I would say, because although I'm a pediatric therapist, I've also worked in adult rehab for many, many years in the US. And I still see adult patients in my clinic. I still see, you know, few, but I still see. So this is what I just wanted to add to both of your excellent presentations.
I think thank you, Ushma, because thank you for doing a recap of my presentation, because I think what I highlighted in my presentation was exactly what you said, that, you know, follow the pyramid of learning and look at pyramid of learning, and it's the same thing that we're talking about. And when we say, and as I said earlier also, that we're talking about SI dysfunctions in developmental disabilities, which means SI dysfunctions exist across all the disabilities. Today we were just focusing on ASD, and we were really not looking at other disabilities. But thank you for actually doing a recap of my presentation.
Thank you. Can I request Pashanti to ask the question? I think she's asking about Dr. Pooja. There is a question in the chat box. My question to Dr. Pashanti, please go on.
Yeah, hi. Hello, everyone. I'm a speech therapist, but I'm also sensory integration. I know a little bit about sensory integration because of my certification, but I don't practice anything regarding occupational therapy. I do see a lot of children on the spectrum because I work as a pediatric speech therapist. My question is, when I see a child who is seeking sensory input, he might be undersensitive or seeker to a particular sensitive, for example, touch. Okay, so now like Dr. Anjali pointed out, they might have mixed sensitivities also, and the same sensory system might have mixed sensitivities over a period of time. So my question is, do we then provide that in play as a sensory input because they're seeking. So for me, if I give them that pressure, if I do pull their leg, they are saying pull. Okay, so for as a speech therapist, I use sensory input as a in an interactive play so that I can get words and communication out of them. So I'm a little confused in this sense where they seek the sensory input, but when I see them after 3 days or in the next session, they might not like the same sensory input. So is that pertaining to the mixed sensitivity that we spoke about? And if yes, what should I do?
Oh, well, I don't think I'll be able to give you the entire answer to this particular question in few seconds. I really like your question, and this is the most confusing area when we talk about, especially we talk about sensory modulation. I think a very simplified answer to this would be that you go with an hypothesis that you have formed, look at what happened before the behavior, look at what happened, what might have triggered the particular behavior that you're seeing in the environment due to the environment. Based on your clinical observation and your clinical reasoning, you're going to try, you're going to, the whatever input that you're using, look at what is an adaptive response that you're getting to confirm that what you're doing is right or wrong. You may have to then look at what has been the change in the behavior, or what do you see as I said, most importantly, I mean, the SI word would be what is an adaptive response the child is giving you, to confirm whether your assumption that whether the child is seeking or avoiding would be justified or would be clear in your head. But again, I'm sorry, this is something which will be which is answer which will probably take a while for me to explain to you what all about, because I'll also have to understand what are the other challenges this child is showing, and this is where SMD becomes a huge challenge. But to simplify and put it in a very, very simple, quick fix answer, I would say what input you are using, what is an adaptive response the child is exhibiting, are you getting a difference in the child's behavior because of removing or adding the input, going back to what is your assessment telling you about this child. So you might have used a sensory profile, you might have used your clinical observations to decide or to draw a conclusion or inference about whether it is under or over responsiveness. I'm not sure whether I've been able to give you the entire answer, but it's really hard to give that complete answer. But just in nutshell, in a brief, if I have to say, I would say, look at what is an adaptive response the child is giving you to confirm your hypothesis that this child was seeking input or was avoiding inputs. And therefore, I made this change in the environment, and I made the change in my reach or my approach with the child. Does that make sense?
Yes, it definitely makes sense. The problem arises when, see, the thing is, I understand as a speech therapist, I'm using the sensory system for immediate responses. Because the OT is where, we look at a long-standing change, because that is not what I'm causing. So when I use the sensory system for interaction, so what I find is a difference in response, and I'm modulating accordingly. But where I have questions is a long-standing change with that sensory system.
Absolutely.
Is very confusing. Yeah.
And I think this is where, it's a very good point you raised, because one of my very passionate point that I'm going to convey to you here is that's where, especially with autism, the team effort and transdisciplinary care is extremely crucial. Unless, as an OT, I talk to a speech therapist, or as a speech therapist, you talk to an OT to say, this is what I observed in my session. What's your take on this? This is what the parents are saying with respect to that particular sensation at home. And this is how it's impairing the child, affecting the child's functional skills and so on. And that is where those exchange of ideas to say, this is a strategy which worked with me. Did it work with you? And what modifications can I suggest to the families? So with this, for any child, but more so with a child with autism, the transdisciplinary and a team effort is extremely crucial to draw any inferences and to have long-term change in the child's learning and functioning.
Yes, definitely. And we should thank the platform for that,
Yeah.
conducting
Yes.
a wonderful, platform for us to discuss and connect as well. Thank you so much, Dr. Anjali. Thank you for answering.
My pleasure.
Thank you. Thank you, Doctor.
And I'm happy to, I take this conversation later on an email. My email is there in the presentation. Do write to me.
Yes, I wrote that down. I'll jot down some questions.
Okay. Thank you.
Thank you. Yeah.
Am I allowed to ask a question, Dr. Ravi?
Yeah, please go on, madam. Please go on.
Yes. My question is to Dr. Anjali Joshi.
Yeah.
We do see a lot of children with, oromotor difficulties. And either that could be, like you mentioned, hypotonia, which is resulting in children not being able to chew. But children who are able to chew, and parents come nowadays, a lot of parents are coming and saying that isko bhook hi nahi lagti. So interoception, is what I understand. How do you really help? Because the child just doesn't want to eat. The child is able to chew, but doesn't want to take. There's a gag, immediate gag. The moment you give, either it is a gag or it just turning away the head. So it becomes really that is a major problem, and the rest of the other issues become very less for parents. Even if we as therapists see them, nahi, ye bhi hai, look at the muscle tone, look at under responsiveness, see the way he is sitting. But no, my child is not eating is understandable because the child is not gaining weight. So just if you can, in short.
Yeah, what you said is right. It's all Indian mothers or garam garam khana mera bachcha khayega to main achhi maa hu. That is something which is ingrained in all of us. So yes, it's a huge concern for most of the parents. I mean, to an extent that the parents will say a 7-year-old and a 9-year-old is in a diaper, they don't mind, but the child is not eating is a concern. And we must respect their concern and not push our concern and say, I don't care whether he's in a diaper. Doesn't happen. I mean, we don't really do that. So yes, what you said is right. It is interoceptors is one. Now, the beauty of integration means that, when you're addressing other areas of sensory systems, you're indirectly also working on that particular system which is under responsive or which is not functioning correctly. So you're really not directly working on the interoceptors per se, but if you're providing right kind of sensory integration, you're looking at an adaptive response at every point of time when you're giving a sensory input, you're indirectly working on the interoceptors. Having said that, other ways of building up the interoceptors, and which is where, especially with respect to feeding, it's so important. There are a lot of times that children are not given a chance to sense what hunger means. So typically what one would see is there is timely feeding, irrespective of whether the child has registered or has indicated in any form desire or empty feeling or feeling of hunger. So even changing that strategy and waiting for the child to show some form of a response and then verbalizing and say, oh, you're hungry. Your stomach feels empty. And then providing the food to the child is another external strategy. So, when you're talking about sensory integration, that's one approach an autist system uses, right? We're looking at many approaches and many ways in which we're going to work with a child. So when we say that teach the parents to recognize and teach the child to recognize what that sensation is, that becomes another additional adjunctive supportive way of teaching the child what hunger means, which also connects to other interoceptors. So teaching the child what thirst means, teaching the child what full bladder means, teaching the child that you're sleepy, and all these things simultaneously will you work upon along with the sensory integration as a therapy. The third thing is, of course, making the parents realize or recognize or helping them to understand to what extent this is sensory and to what extent this is behavioral. So behaviors, for any behavior to emerge or any challenging behavior, there are many reasons. So escapism, attention could be another way or a reason for child not taking in any food, because he's realized that when I don't take that food, Mom runs after me, so that's my way of communication with her, or she gives me biscuit and I get what I want. So there could be another angle to it. So exploring that angle to see whether it's lack of appetite or dislike for food is coming out of that. The tactile element is another element, of course. The child probably is not eating, or because he doesn't like a certain kind of texture, he doesn't like smell. So one is going to explore all these areas to see what is causing the problem. But what I want to highlight here is it's not only the sensory that you're going to look at. You're also going to look at what is an environment like, what is triggering this behavior, what are the reactions and responses this child is getting, and work on the interoceptors, as I said, through your therapy, through communication, to explain to the child what it means to be hungry, what it means when you take him to the toilet and you say, now you're feeling good, you did so, and so on. So communicating those sensations to teach the child what the sensation is, and working on other areas would be some of the ways in which one can work on addressing hunger, appetite, and feeding issues. I mean, I'm not even talking about oromotor areas there, which of course I'm sure you must be working on. So I'm really not touching upon that area here.
Yeah. Thank you so much, ma'am.
Yeah.
Thank you. So I
There's
think
somebody raised their hand. Vandana.
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 Yes, that's me.
Okay, please go on, madam.
Is it okay? Do we have the time for my question?
Yeah, please go.
Sure, thank you. Thank you very much, Anjali ma'am. That was a lovely presentation. It's a pleasure to learn from you. So my question was more to do with the older children. There are many children who seem to be on the borderline where they don't exhibit anything frank as a disability, so to say. They somehow manage through the early schooling years. And by the time they are adolescents, by the time they are 13, 14 is when the problems become more obvious in terms of both psychological, emotional issues and physical issues. So there are a couple of children that I've seen over the course of my practice with Asperger's who were diagnosed as Asperger's by accident, but they've led normal lives, so to say, normal in brackets.
Yeah.
And yeah. So they have issues with food and movement and a host of other psychological, emotional issues. My question was more to ask you, where do we refer these children? How do we go about their treatment? As in terms of referring them to the right place. I, as a PT, can take care of to a certain extent of the motor issues, but unless the other issues are addressed, we're not really going to make much of a difference. And the parents send them to yoga and mindfulness and meditation, and we seem to be running down a blind alley this way.
This is, again, this is Vandana, this is a question very dear to me. And why, I'll tell you why it's dear to me, because I was heading a program called the Pritpal training program. And the training program was primarily to train physical ed trainers and special educators to teach how to teach sports skills to children with special needs. And I've seen tremendous difference in these older children just by introducing at the right time, right form of physical activity. This is more so, I've also experienced this during pandemic when I was seeing children online, and the kind of difference that the kind of deterioration that happened in the last 2 years just because of lack of physical activity.
Yes.
That's one aspect. But the second aspect also, and again, why I'm emphasizing so much on the physical activity and more in the naturalistic environment and outdoor activities, because that's something age appropriate. I often feel that when a child who's 14, 15, or in short, if the child who's taller than me comes into my therapy room for therapy, am I really doing justice to this child? Is this how the world is? The world is not one-on-one. The world is all the people around, and this child really needs to socialize and interact and engage. And you're talking about, the older diagnosis of Asperger's, where that's where the concern is. This child is really not fitting into the environment. And to these parents, I often, my suggestion to them is, yes, maybe this child will require some amount of consultative OT at some point of time, especially because the child is likely to have some kind of writing issues and perceptual, visual perception issues and attention issues. 100% he's going to benefit from OT, probably consultative OT. He's also going to require support from a special educator or an educational support to overcome some of these challenges. But most importantly, we need to create outdoor opportunities for these children so that they're able to learn, or they're able to work upon their body systems and their motor systems and sensory systems through play and through outdoor activities. Interestingly, in 2019, there is an American Journal of Occupational Therapy talking about the only evidence-based intervention as an adjunct to SI and OT has been one form of Chinese massage, and the second one has been yoga. So yoga has been found to have intense, it's an evidence-based support activity which addresses sensory processing dysfunction. So I think to answer your question in short, I would suggest at least starting the right form of physical activity, outdoor activities and yoga training would be a good way of not only working on the proprioceptive vestibular systems of this child, but also to facilitate social interaction and engagement.
Lovely. Yep. Thank you, ma'am.
Thank you.
Thank you so much. Thank you so much, audience, for the question and discussion. And thanks a lot to both the speakers. We had really wonderful session. And I thank you, Comhad and Dr. Ravi, for giving me this opportunity to coordinate these two very, very wonderful lectures. So I think we have come to an end. I'd like to hand over to Dr. Ravi for closing.
Thank you, Pooja.
Thank you, Dr. Pooja, for moderating the session, Dr. Pritpal Singh, Dr. Anjali, and all the audience who have stayed back till the end. Thank you very much for this. And I would like to highlight, we are planning to have more such sessions with therapists. I'll keep you informed. Kindly join the Telegram channel link, which I've shared it in the chat box. And hopefully look forward to see you all again and have an interactive discussion. Especially it was nice to hear from a physio and also from a speech therapist. And hopefully this interaction will help us to learn from each other. Thank you. Please have a look at the chat box. Thank you.
Thank you.
Thank you, Dr. Pritpal Singh. Thank you, Dr. Anjali. Pooja.
Thank you.
Thank you so much.
Bye. Good night, all of you.
Thank you so much, everyone.
Thank you, ma'am.
Good night.
Thank you, everyone.
Advice to